Good afternoon. I'm David Cassak from In Vivo magazine, and it's with great delight and also, frankly, a little sadness that I welcome you to the seventh and final in our series from the Innovators Workshop, discussion with leading medical device entrepreneurs and innovators. You know, over the last 6 sessions, we've heard from physicians, engineers, entrepreneurs, and a fascinating array of different perspectives. And in today's interviewee, we kind of capture all those perspectives at once, plus a PhD, in a way that no one else really has. Straddling the line between academic medicine and technological innovation, Bill New has crafted an amazing career in the medical device startup community, one that seems to have no end in sight. And so, Bill, with that, I think you represent a very fitting close to this series. Welcome and thanks for coming here.
Thank you, David.
I know that your association with Stanford began very early in your own life, but before we get into your formal education, talk to me a little bit about your youth. I take it from some of the things I've read about you that you were pretty inventive as a kid, taken to creating things. Is that true?
Yeah, I was one of those kids who learned to read very early on, and then my mother had difficulty keeping me in books, so she would go to rummage sales and buy them by the pound. And the most interesting books actually were Cub Scout books, Boy Scout books, because they had projects. And so I would start working my way through these books, and the most fascinating project probably I had was building a crystal set, a radio. And I remember that evening, it was about 7 in the evening, and I heard KGO. And that probably changed my life forever, that you could take little bits and pieces and you could communicate, albeit one way, with a human 30 miles away.
You were also somewhat innovative with tape recorders, because I know that led to some early work that you did once you graduated. But talk about your early fascination with tape recorders.
Well, the radios, you know, led to almost anything that had to do with audio and whatever. And I had heard that the Germans during the war had made a wire recorder. So I found a roll of wire someplace up in a war surplus store in San Francisco. And so I started playing around with it and see if I could make it record. And I could, you know, I mean, understandable to a voice. And it so happened that my mother, who was doing a PhD in child psychology, I wonder why, here at Stanford actually had the head of HR for Ampex in her class and introduced me to, and she mentioned him, well, you know, my young son here built a recorder, right? Well, that was sort of staggered the imagination, but he said, well, you ought to bring it in. So make a long story short, I brought it in, showed it to the Ampex guys, and before I know it, they had offered me a job. So I was in the building and designing tape recorders.
How old were you at that time?
Oh, that would have been about 1956. I was about 14, 15 years old.
That's interesting. So did you work at Ampex before you went to college?
Oh, yeah. No, in fact, I had some of my first patents, and I was by far the youngest guy, but, you know, we had a good time and designed a lot of stuff.
And not surprisingly, your early training then actually wasn't in medicine, but was actually in engineering. You went to Stanford to get your degree in engineering. Talk about that. It's obvious what attracted you to engineering, but what did you think your career was going to look like? And were you also, in addition to Ampex, worked at Precision Instrument and Hewlett-Packard? What did you think you were going to be doing during that time?
Well, actually, when I started at Stanford, I started as a physics major. Right, and it's somewhere in your sophomore year of being a physics major, you sort of come to the epiphany that there's nothing physical about physics, right? It's all Maxwell's equations and all this sort of stuff. And I remember sitting there at the end of a quarter on electricity and magnetism and realizing that for an entire quarter I had not even heard the word electron. And I realized there's no way I'm not a physicist. So anyway, I ultimately would sort of follow my love, which was electronics and electrical engineering. And And at Ampex, actually, this was a very revealing moment. I had to drop out of school. I was largely supporting myself through school. So I working nights and gas stations and whatever, and it was getting too hard to do, particularly as a physics major. So I dropped out of school for a year, and I went back to Ampex, and I noticed that a couple of fellows weren't there, engineers, fairly good engineers weren't there. And I said, well, where have they gone? And they said they went off to start a company. And, you know, at that moment in my life, I had really never thought that people started companies, right? So it got better. And about 4 days later, I got a call from one of these guys, which was sort of the proverbial, let's do lunch. Sure, I'll have lunch. And was offered a job to come on over and work for them. And
what company was this?
That was Precision Instruments. And they had decided that they were going to take tape recorders and shrink them all the way on down, small enough that they could go and do satellites of this sort, because this was about 59, 60, something like that. So they said, do you have any idea how you could make a tape recorder smaller? I said, oh yeah, you could probably make it 10 times smaller, right? Well, watch what you say, because that's what I ended up having to do. And so I started designing tape recorders. And Hewlett-Packard, interesting thing, Hewlett-Packard bought a company on the East Coast that was making Sanborn electronics, made EKG machines and whatever, with lots of paper, and realized that HP decided that maybe paper should go the way of the dinosaur, that all physiologic signals ought to be recorded on tape, but they didn't know anything about tape recorders. So again, they started rounding up sort of the hot shots in the tape recorder business, of which I guess I was one of them, and we were suddenly up at HP Labs, and we were designing tape recorders. So I got to do it again. But of course, the most interesting part at HP was you could go poke around the rest of HP Labs, right, and meet some really interesting people and see some very interesting things. So it was like a kid in a candy shop.
But that's just that was the beginning of your introduction to medicine, because sometime in the 1960s, you made the transition to medicine. Was it that work that you did at HP on those physiological measures, or did you simply decide that you had such a natural bent for engineering? Why did you go switch to medicine?
Well, there was sort of a prelude to that, and then probably the real story. The prelude was that the doctors at Stanford Hospital who were using these Hewlett-Packard tape recorders and Precision Instrument tape recorders would always call up the factory to have them send out a field engineer every time they wanted to run the tape recorder. Well, that's a little expensive, customer support. So one of them came, one of the customer support people said, you go to Stanford, right? Yeah. Well, you really ought to look in on this doc, and if he wants to run it, I mean, God knows you know how to run the tape recorder. I mean, you designed it. So I went over to see this doc, and he says he thought this was a stellar idea, offered me a research assistantship, which paid all my tuition, which I thought was a stellar idea. And so that was sort of my introduction tangentially to medicine. But the coup de grace was when at the draft lottery, I drew the number 6. And I said, no more draft deferments. No more draft deferments. Well, there must be some draft deferments. So they said, actually, there are two. There's divinity school. Well, that took me about a millisecond to digest that. And there's medical school. And I said, frankly, if you go to divinity school, all those guys become conscientious objectors. So, they don't care about that. And if you go to medical school, they're going to draft you as a doc. Well, okay. So off I went to medical school. And frankly, I knew almost nothing. I mean, an enzyme, that's what was in a box of Tide, right? I mean, I didn't know anything about it. So it was a real total immersion. And so I went to Duke in their MD PhD program with the intention that I would finish up a PhD in engineering. But what I discovered very quickly after about a year or so is that engineers had some really neat, elegant solutions, but didn't have a glimmer as to the problem. And the doctors had some really cool problems, but we're absolutely clueless as to the solutions. So it sort of struck me there was a natural interstice, a place that you could get in between them and make some real headway.
Do you, when Mir Imran was here, we raised the question of how engineers captured that intuitive sense of clinical solutions, and you're making an argument that there's a flip side to that, which is that engineers have a better insight into the technical side of how you get to those solutions. But to your mind, as your career has evolved, do you think of yourself more as an engineer who has medical training, or more the doctor who has a strong technological or innovative bent? Is there one kind of mentality that predominates in your own background?
No. I mean,
you're a doctor twice over. Are you more an MD or more a PhD?
I'm sort of a chameleon in that sense. I'm probably more an MD. I'm probably a more MD because the patient and the patient's welfare is what drives me more than the research refining. I mean, my view. I mean, I know it's an ugly little view, but you shouldn't do any unnecessary research, right? I mean, you do research if you have to, if you can't solve the problem. But if you can do stuff with off-the-shelf technology and off-the-shelf knowledge, and go do it. I mean, that's the engineer wanting to make tools and make a difference, and the doctor is wanting to make a difference in patients' lives. The researcher would be the one who would sort of enjoy, the deliciousness of the research and the intellect. And while that's fun and it's elegant, and I like it as well as the next guy, without making a real contribution, a real tool that can make a real difference in a patient's life, it's not really, doesn't have much interest for me.
You're raising a point which I was going to ask you about, which is whether engineers and physicians think about problems differently. You seem to suggest they do.
Oh, yeah.
But do you ever find yourself saying to yourself, well, if I put my engineer's hat on, I'd think about this problem this way. If I put my doctor's hat on, I'd put it that way. Is it really about patient care versus tools off the shelf? Can you
Well, they do. No, they do look at the world in different ways. Engineers are fairly analytic. I mean, I didn't study all that hard in engineering school because once you sort of understood the basic principles, you could sort of work it out on the fly. Mm-hmm. Well, there are not many basic principles in anatomy, right? It's this book this thick, and there's this cadaver. And, at the end of 6 weeks, you're going to know all these bits and pieces, and it's a lot of memory. And to an engineer who sort of wanted to know why, it was a different way of learning. I'm on dangerous ground here, but I can take an engineer and muddy up his thinking enough to make him a doctor. But I'll be damned if I can take a doc and, really teach him, real calculus, real, C programming, I mean, they're just not wired that way. I don't know whether it's self-selection or what it is, but I mean, they're just different.
Although one of the criticisms often made about medical device entrepreneurs is they so fall in love with their technology that they lose sight of the way the doctor really looks at it. You're raising an interesting point, but I wonder whether that sense of fascination with technology doesn't undermine some medical
Well, that
device
entrepreneur that you're talking about is clearly an engineer.
Yeah.
Because the reverse is true. I mean, you can see doctors who are so in love with their technique or whatever it is, and I mean, you look at it, from any sort of a scientific or technical point, and it's egregious, right? I mean, God, I would use this on my dog, and you sort of, gently try to point out that, God, maybe we ought to make it so at least it doesn't have a shock hazard, and it uses something other than sort of, big lantern batteries and for a power supply, and, I mean, oh, no, it works just fine. I'm sure that, and I mean, and they're actually convinced that they got the greatest thing since sliced cheese, right? And so each of the worlds are different. And the Zen is sort of getting best of breed, sort of the best parts of medicine and the best parts of engineering and folding them together, preferably in one cortex so that, they can sort of talk to each other. it's difficult enough to have a doctor talk to an engineer because they have different vocabularies, they have different worldviews, they have different value systems. If it's all in one cortex, you can have a conversation with yourself in the shower, and work out lots of interesting problems.
Now, your medical training was in anesthesiology. Why did you choose that field?
Well, I started off in cardiology, and indeed my PhD was in cardiac electrophysiology. I was quite interested in sort of what makes a heartbeat beat or what makes a nerve work. I mean, I was interested in nature's electronics or electrically excitable cells, and I knew how to do it with, with transistors and do it in man-made stuff. So I wanted to understand how nature did it, which was interesting. But that led me straight away into cardiac stuff. But if the truth be told, most of cardiology is chronic disease, congestive failure, intercurrent other disease, chronic pulmonary disease. And, these are people who don't necessarily take their meds, and it can sort of get to you after a while. And I guess fundamentally being, truth be told, fundamentally ADD, I like to see things happen now. How about the 1 yard line of life? So, that's anesthesia. Besides, lots of gases, lots of pumps, lots of electricity, lots of little things that go beep and beep and beep. So, to an engineer, right?
Lots of buttons to push, lots of levers.
That's the real stuff. So.
And yet you went from there into academics. Didn't you teach for a while? You could hardly get further away from the 1 yard line than academics.
Not if you take a brand spanking new medical student and you put him in front of a patient, which is on the 1 yard line of life. Say, son, what would you do? And as they start to tremble, right? It's good for the character, and they learn. And some of them very quickly decide they're never going to go into anesthesia, they're never going to go into surgery, and they all become psychiatrists or dermatologists or something of that nature. But there are other ones who say, this is really cool, and then those are the ones you want, right? And pluck those out, and they become the next generation.
Was there anything about your early work in tape recording technology that you could apply to anesthesiology?
Oh yeah, actually there was. I will never forget this. I mean, I'll try to keep it simple, but it is a little technical, sort of interesting thing. If you took a standard strip chart recorder, that EKGs were going on, and you put a square wave on it, you just put a little square wave on. Of course, what it would do, the square wave would always sort of have a little overshoot, right? Sort of thing. Well, you knew that wasn't the square wave, right? Square waves are square, right? So, and the engineers will realize that that's because the phase response and the amplitude response, doesn't have a linear phase response, and so, an engineer would go correct all that, so that when you put in a square wave onto a piece of paper, it would look like a nice little truncated, square wave. You'd taken off the higher harmonics, but it would just, it would nice and symmetric little Gibbs ears. It looked very symmetric, nice square wave. And that's, of course, recording what really ought to be there, right? But if you put an EKG through that, it completely changes what an EKG looks like. It actually makes the EKG look like it ought to look, but it's not what doctors learned. So doctors would look at this thing and suddenly decide the guy's had an infarct, right? Yeah. Well, no, he didn't have an infarct. You're actually looking at the real EKG. But no, take it back to the way it was, right? So you take it back so it's had bad phase response and everything. And, suddenly the EKG would look the way they were used to seeing it, and everybody felt comfortable again. And I mean, that would be an example. Another example I won't go into, but I'm sure every single engineer who ever went through medical school, when they looked at the notion of putting, sort of two pieces of garden hose, one in each ear, down to sort of an orange juice can and onto a stethoscope, said, oh God, I ought to be able to make a better stethoscope. Well, the problem is if you make an electronic stethoscope, a very high fidelity stethoscope, it doesn't sound like two pieces of hose in your ear, right? So you don't learn what, quote, the proper sounds are. So there's many examples where if you actually try to improve the technology, you actually change the practice of medicine beyond where it can absorb.
It's comfortable. Actually, it's interesting because both around visualization and the advent of computers to technology, people said the same thing, that actually in the wake of computers coming to technology, doctors have to deal with a level of distortion. The distortion may simply be that it's not the way they've been trained, but in fact may be a more realistic display or manifestation of what they're actually seeing.
Well, and that's the zen of it without getting into it. You say more realistic. You see, an engineer would say more realistic, meaning it's closer to truth. And a doctor would say it's more realistic in that it's closer to what they know, right? And that's a good example where the sense of what is truth, what is reality, what is perception is different between engineers and doctors. And without going into it, even completely different for lawyers.
I don't think we want to get into it.
We don't want to go there.
In fact, one of the few advanced degrees you don't hold. We want to get into Nellcore, but before we get into Nellcore, you are, I think, the only one of our innovators who was formally trained in business. So around 1980, what prompted you to leave a career in academic medicine to go to business school?
Well, I had a sabbatical coming up, and I'm sure my department chairman was convinced I was going to go to the NIH or the Karolinska or, go off and do something of that ilk. But I had been through the 70s, which had been very highly inflationary. And I was struck by the fact that in real terms, healthcare was consuming an ever-increasing percentage of the U.S. GNP. In fact, it was probably up to something like 12, 13, 14% about that time, approaching 15%. In fact, I don't think anything had ever consumed 15% of the GNP except for the defense budget in 1943. Right? So I said, trees don't grow to the sky. And I remember looking at my colleagues and saying, somebody's got to have to get their arms around this. I mean, we're going to have rationing here pretty soon. And everybody poo-pooed me. Oh, no. Americans have an endless appetite for healthcare and youth and whatever, and deep pockets. I say, yeah, deep pockets. I bet they got short arms. I mean, this is not going to do well. And so I said, somebody's going to start rationing, and if you leave it to the politicians and bean counters who are clueless about healthcare, medicine, I mean, they will cut in God knows where. Maybe some doctors ought to learn about managing scarce resources getting scarcer. So how about going to learn something about management, school of management? And people told me that was the dumbest thing they had ever heard of. And I remember coming into my department chairman and saying, well, I've decided what to do with my sabbatical. And he says, oh, really? And I said, yeah, I've decided to go to business school. And there was this long silence. He says, that's the most Philistine thing I've ever heard of. And he says, I absolutely won't permit it. And I said, well, in that case, sir, I guess I quit. And he looked at me, quit? God damn it, you can't quit. I just put you up for tenure, for Christ's sake. And I said, well, it sounds like you've got a problem. And, it's probably the first time in public I've ever said this, but about 2 years later, when I had started Nellcore, I would get a letter from the same department chairman asking me if I, Nellcore, would sponsor him to go to business school.
What did you say?
I didn't know what to say. Because, no matter what you said, you would embarrass somebody. So I just burned the letter.
Well, that in itself is a kind of response.
Yeah.
You said before that when you went to Precision Instruments, it had never occurred to you that people actually started companies that you didn't. And obviously, when you're working in an academic institution, particularly one like Stanford, it comes with such a long tradition. almost immediately out of business school, you started Melcor. First, tell us where the idea first came to you. I heard it came to you from long ago, one of your Cub Scout adventures.
Well, yeah, I mean, it came to me. I mean, the notion of building an oximeter, a thing to measure oxygen in the blood, came to me when I realized during the 70s that as anesthesiologists, we were being taught everything there was about hearts. So we would put in Swan-Ganz catheters and arterial lines and CVPs and 12-lead EKGs, and we fixated on the heart. Except people kept dying, even though we knew everything about their heart. Well, it turns out that people do die of heart disease in a coronary care unit. But if you just take all those cardiac monitors out of coronary care units and you just simply move them over and put them in the operating room, it turns out that most people in an operating room don't die of a primary cardiac event. Frankly, what they have problems with is something that's respiratory. They run out of oxygen. Now, there's a million and one ways to run out of oxygen, and I had residents who could invent new ones by the week. And, a hose would drop off, or the ventilator would stop, or the endotracheal tube would go down the wrong way, or you'd turn the wrong knob and turn off the oxygen, turn on nitrous oxide, or the tank would run dry, or that you put the tube down too far so it was only in one lung, or the surgeons would decide that they needed some place to rest their arms while they were working, so they would sort of push down on the only side of the chest that was moving. I mean, it just went on and on and on and on and on. But the final common pathway to disaster is that the patient would slowly start running out of oxygen, and then they would start to develop cardiovascular problems. Their blood pressure would start to go, they get a little arrhythmias and whatever. But if you were waiting for that, this was way after the thing. So, my view is, well, why don't I, is there a way to see if the patient is pink, well oxygenated and well perfused? Now, the notion of a flashlight is when, as a kid on a camping trip, you'd always, often put a little flashlight in your hand, when you're sitting there in your sleeping bag and it's dark except for the stars up there, and you'd put the thing and you could shine the light through your hand. Of course, it always looks pink, And if you shine the light out toward the tips of your finger, you discovered, in fact, you can just do it on yourself. If you sort of scrunch your fingernail about halfway, you'll push the blood out of the tip, but you'll see the blood lines of the pink line be right in the middle of your nail. And if you sort of watch it very carefully, every time your heart beats, right, that little line will sort of move a little bit. So I said, well, if I put a little light bulb on one side of my finger, a little photocell on the other side of my finger, I should be able to watch my blood pumping. And if I could figure out what the color of the pumping blood is, and if it's bright red, it's full of oxygen. And if it isn't so red, it's not so full of oxygen. So, I got a couple of different colors, LEDs, and a little photocell, and put it together, put it on myself, put two little traces on an oscilloscope, and held my breath. And one pulse got big, and the other pulse got little. And then I started breathing back normally, and pulses came back, and I said, this might work.
Well, that suggests a fairly smooth technology development. Was it a smooth technology development? How long did it take you to actually develop a monitor?
The technology development fundamentally went fairly straightforward. There were probably two sticky wickets. I mean, the technology, actually, if truth be told, wasn't all that much, although this was back in 1980. I mean, it was an 8085 little 8-bit microprocessor and 4K of code. I mean, when I tell my kids 4K, I mean, they don't know what 4K is, right? 4 meg, they said. No, 4K. But that was the whole oximeter. So the technology wasn't all that much. There was really two issues. One, making it work in an operating room, which is a pretty hostile environment with all sorts of bovies and electric cauteries and other stuff going on. So you had to make this thing work very seamlessly in a fairly hostile environment. So that took some doing. But the other part of it is that convincing people that they ought to measure oxygen.
Right.
And that took a while until finally sort of, it dawned on me. We don't want to measure oxygen. We want to measure the lack of oxygen, right? So once you started telling people about this measures the lack of oxygen, my patients lacking oxygen. I've been practicing 30 years. I've never had a patient run out of oxygen. And of course, my instant reaction was, well, how do you know? I never looked. And generally, you had to first convince people that patients ran out of oxygen.
Were patients before this not being monitored in the operating room for oxygen?
You look at their fingernails, sort of squeeze their fingernail, you know, maybe. And that's about maybe be all you'd see, right? Because you can get, they're all covered up. You know, you couldn't see much. So, and if you really had any doubts, you know, you'd go stick a needle in their artery, radial artery or something, or send a blood, sample of blood all packed up in ice and, airtight little glass syringe and pack it all and send it off to the blood gas lab. And 20 minutes later, you'd get back a single number of what the oxygen was 20 minutes ago, which struck me as being semi-irrelevant. But particularly if it was low, God forbid what it is now. And so at any rate, I just said, the problem with oxygen is something you ought to sort of know now.
But it's funny, when you were talking before about the different perspectives that an engineer would have and a physician would have, it seems to me that the most striking area where that would manifest itself would be in adoption. The engineer saying, we can do this, and the doctor saying, well, why do we need to do it?
Yes, there's a lot of that.
Yeah, today you would demonstrate that by doing clinical trial studies to show that measuring the lack of oxygen and finding X, delivers a good result in Y% of the cases. In those days, how did you make that argument?
Well, it was much easier in those days, right? I mean, I would come in the morning, right? We'd start cases, and I'd be the anesthesiologist, and I'd use the instrument for a while, and by about 4 in the afternoon, when the list was done, we'd finish off, I'd go back and take the instrument back and tear it apart, get out my soldering iron, or start disassembling a little code, and I'd tweak it and do what I thought would be the best way to do it. And the next morning at 7 a.m., I was back trying it. It was a highly iterative process. IRBs? What are IRBs? Right? I mean, in those days, it's 20 some odd years ago, most people just, if you wanted to try something, you tried something, and it was sort of, you would try to ethically do the right thing, which I think everybody did try to do. And I think the regulatory overhead and the regulatory burden today has made innovation much, much, much more difficult.
Mm-hmm. But how did you, obviously you could convince the surgeons that you were working with in your cases that this was something valuable. How did you communicate the same thing to a surgeon in Chicago or Dallas?
Well, your customer wasn't the surgeon, right? Your customer at first, your customer was an anesthesiologist. The first customer would be an anesthesiologist who actually believed that their patient actually might run out of oxygen, right? And that was pediatric anesthesiologists, because little kiddos, they got sort of no capacity, and they turn blue in a heartbeat, right? And kids are always stopping breathing and turning blue, and pediatric anesthesiologists didn't take that as an assault on their personal confidence. Those are kids, right? They did what they could do. So they knew their patients run out of oxygen. So you could bring it to them. They thought, oh, that's kind of neat. We can actually, measure it and quantitate it a little bit. So the first step was to get pediatric anesthesiologists to use it, right? And then, of course, the next step was to get the other anesthesiologists to start using it, and they would start to use it on patients who they believe might be at risk of running out of oxygen. But that actually wasn't the most important patient. The most important patient to use it on was the patient who you didn't expect to run out of oxygen, right? That was the zen that you had to get to, and I knew we were there when anesthesiologists, if their own kid was in surgery, or their own wife or their own spouse was in surgery, would make sure they had a pulse oximeter. Then it was pretty straightforward. So you'd use it on your own wife, yeah, but not on the rest of the patients, right?
A lot of the physicians that developing their first technology simply wanted to get the technology into widespread use, and so they went to other product companies and wound up starting companies almost by default. No one else would take the project on. Did you begin from the beginning thinking that you wanted to build a company around Nelcor? How did Nelcor itself come into being as a startup? At what point did you say to yourself, I want to do a company here rather than just develop a technology?
Well, I actually started with the premise of building a company, and because I knew that as a vehicle to bring technology together with patients who were on the 1-yard line of life, people who were critically ill, for whom time made all the difference, and if you had a better tool, you could probably save seconds and minutes. So I actually thought about building a company as a vehicle. The notion of oximetry came actually probably some weeks after I had thought about starting a company, when I had sort of sat down with my partner, Jack Lloyd. He was the LL and I was the NE, so that's how you got NELL, right? The third guy who came on was a guy named Jim Korenman. So we told him that if he came on board, we would name the company after him. Actually, had he not come on board, we would have still called it Nelcor, but he didn't know that.
Well, you gave it 3 letters instead of just 2.
You're right, Nelcor. And I mean, that's, as I said, the ideas come to you in the shower. So that's where Nelcor came from, and taking a shower. But, I and my partner, Jack Lloyd, sat together, and he was an experienced entrepreneur in the ophthalmic space. He had helped engineer, who had helped design things for refracting eyes and ophthalmology. So he sort of came from the technology, knew a little bit about healthcare, and a fair amount about business. And I was, in a sense, the complementary set. So we sat together, and I started sort of running down all of the problems that I thought were unmet, that people were spending money, that had a high incidence, had a lot of problems. And in those days, about 10 to 20,000 people a year out of the 20 million operations were coming to real grief, an anesthetic disaster. So and malpractice rates were sky high, $100,000 a year for premiums. So I said, this is a problem.
So obviously you were fundamental to creating the technology behind Nelcor. How much did you participate in actually running the company and the day-to-day management of it, or did you leave that to Lloyd?
No, I was very much. I was largely involved with the outside, with the doctors, and with the product, and with the technology. And my partner, I mean, this is very coarsely divided, tended to focus more on the inside and the operations and sort of the business side. And the other founders that we had, had very strong strengths, one in technology, engineering, and one in the financial and administration. So sort of between the 4 of us, we had covered the waterfront.
Of the 3 careers that you've had then, engineering, medicine, and business, entrepreneurship is the one you stayed with. So ask the question whether you took to it may seem unnecessary. Obviously you took to it, but did your business school training prepare you for what it was like to run a startup? What were your early days like? Was it a rude awakening of what it actually meant to run a company?
Well, first of all, why be an entrepreneur? Or indeed, more generally, why be in business? Business is general management is the most general thing there is. It covers all kinds of problems. The difficulty with being either an engineer for the most part, or a doctor for the most part, or a professor for the most part, is that they're incredibly narrow, specialized, where the reward system is to dig deep but stay fairly narrow. You get points for depth, not breadth. Whereas in general management, in business, and particularly in entrepreneuring, when you're making the coffee and cleaning the toilets and signing the checks and using a soldering iron, the whole game is on breadth. And so since I have a predilection for the big picture, the broad picture, I found myself attracted to those roles where that was true. And in fact, if there's probably a liability that most academics come at this, is that they come from a world which is in fact narrow and deep, and they have to, in a sense, develop a world which is completely orthogonal to that, which is broad and not as deep. You get, if you want depth, you go get other people who can become drills and drill
So
down.
you stayed at Nelcor for about 7 years. Why did you leave?
I had another sabbatical, I figured. Right? Actually, truth be told, it was, again, I probably haven't mentioned this in public discussion before, but, you know, I had married and family had grown and kids had grown, and, you know, pretty soon I'm living in this house, small house, 25 feet square, with my wife, and I had 3 kids, and all pair girl and her daughter, and the 2 Labradors, and 2 cats. And my wife one morning, after we had taken the company public, after the IPO, she says, about this new house, yeah, if not now, when? And if not with me, with whom? Which I thought was the most succinct distillation of a problem I have ever heard. Oh, I got it. And I went, saw my partner, and I said, why don't you become chairman of the company? I'm going to go take a year off and go build a house. And 3 times more money and 3 times longer in time, I finally had my house built.
But you just didn't build a house. You also formed another company called Novent during that time. What does Novent do? Because
yeah, Novent was really a way to catalyze, both use seed capital, help people who are starting companies, identify useful technologies, identify all the early stuff that you have to put together that early entrepreneurs usually, almost by definition, don't have a full grip on. They have some little part. So the other part, teaching them that there are other parts and helping them with it and putting in a little money to see, in fact, if there's some there. That's what Novent was. I also started actually toward the tail end of that house, Natus, another company, and I started that because, you know, I finally never let an engineer build a house. Because of course nothing is ever exactly right, and so you ultimately end up being your own general contractor, which I was. But there's only so many American standard toilet fixtures and tile colors and 2x4s and stuff you can deal with. So I actually started a company as much for sort of comic relief.
Well, Natus's technology, which is neonatal hearing test, seems far removed from anesthesia, from pulse oximetry. What's the connection, or how did you find that technology? Was it an idea you came up with, or did you?
8085, 4 kilobytes of, I mean, you know, it's the same technology, and you got to understand that, you know, I'm the electrophysiologist, right? These are brain waves, right? That's basically how the hearing works. You put in little clicks that you can barely hear in the ears, and if you can hear it, i.e. you have normal hearing, then by sort of what that means sort of existentially is you get a little brain wave, right? I mean, that's what you mean by hear. So if you can detect a little brain wave every time you make one of these barely audible clicks, you can demonstrate that a kid can hear. And if when you make these clicks, you don't get a brain wave, with high likelihood he can't hear, right? So that was the technology. But that was the implementation, that was the solution. The problem that I wanted to go work on were kids. And I thought kids were really going to be, a scarce resource, getting scarcer. And the entire developed world is below replication rate. The entire developed world is aging. And every kid is becoming precious because there's so very few of them. And the most common problem, among the top 2 or 3 most common problems in kids, is that they can't hear, and nobody knows. And the problem is, by the time somebody figures it out, they've already gone through the formative part of their wiring up all their little synapses. So if they can't hear, they'll never learn to speak. If they don't speak, they won't read. If they don't read, they won't do numbers, and the kid, you know, ends up being remedial. And you know, and I thought, well, this is all avoidable. All I have to do is find out early on that the kid can't hear. So, but in order to do that, you had to invent something that you could test a kid on the first day he's born, because that's the only day you can get your hands on him, because 90% of the kids, well, 99.8% of the kids, 0.9% of the kids are born in a hospital, maybe in the parking lot, but they're born in a hospital. But 90% of them are gone tomorrow morning. So if you want to get your hands efficiently on every kid in America, you got one day. And so you got to figure out what you can do about their hearing. So I had to figure, and I couldn't, even though I was asked by the FDA, well, why don't you do it like they do in school? I said, you mean like raise their hands? They said, yeah. Well, these are smart kids, but I mean, just taxpayers' dollars in action. But so what you had to do is you had to try to figure out a way to do it, and that's how we did it, electrophysiology.
Now, did you found Natus alone, or do you have partners in that as well?
Again, partners. I tend never to start these things alone. I mean, companies get started when you sort of get a critical mass of 2 or 3, 4 people who sort of get it and work well together in good interpersonal chemistry, and each brings something different to the party.
Well, the reason I was going to ask is, were there things that you learned the first time around that you swore you wouldn't do the second time around? Were there things that you did at Natus differently that came directly out of your experience at Nellcor?
Yeah, some of them I even repeated, which shows you that you can have bad luck twice. But yeah, no, there was a huge amount, and in many ways it was easier, and you could sort of go to the next level, which was building a company. In this case, with as it turned out, less experienced people, much younger people. In fact, in the early days of Natus, I think the next oldest person to me was 15 years my junior. So I built it out of youngsters, all of whom would have their first sort of life success together. And in so doing, of course, very quickly they could start to end each other's sentences. They understood they would work as a pretty strong team, and I could seed that by sort of hand-picking a few people from Nellcor, seed stock, and I mean it made a lot of difference to have done it before.
Nellcor's original funding came from venture capitalists.
Right.
Did Natus's as well?
In the original funding we ran it on angels, myself and a couple of my friends from business school. We ran it, probably for about a year or two, a couple of years, 2 or 3 years, until we brought in venture capital.
I wonder whether your perspective on venture capital and its role in medical devices changed between 81 and 88 and has changed yet again since you launched Natus and in your current work, because we're going to talk in a moment about Oregon, but you also at Novent do some seed fundraising on your own and hand those companies off. Right. What's your take on the current venture?
Well, the venture business, like any business, I mean, I've watched the venture business evolve over the last 30 years. And when it first started, and I was first aware of it, sort of in the 70s, I mean, the key guys in it, Tom Perkins, Gene Kleiner, Burt McMurtry, these are strong operating guys. And venture capital in those days were strong operating guys. And that's what they really brought, that experience, that know-how. They had walked in those moccasins. They also brought money, but that wasn't their highest value added. As the years would go on, and their returns, which might have been probably historically 40% ROI or something, would go up and go down, but say it was 40% ROI. When you came to the inflationary 70s and the prime rate got to 21%, you needed to have 40 some odd percent returns to be making 20% real returns. So suddenly guys who are managing portfolios suddenly realize, well, what are these guys doing over in venture capital? So unfortunately, venture capital attracted a whole bunch of sort of finance guys who were clueless when it came to operating, right? I mean, these guys are clueless. And they to largely morph the business into more and more of a finance business and more and more of a banking business. And really, and it started to fill up with young, hotshot, self-important, Stanford and Harvard MBAs, with monogrammed shirts and snapping their suspenders and flying around in the front of the plane. And of course, you had read the same books in business school that they had, so they didn't really bring anything to the party, but they sure felt they did. And so, it really evolved, and to some extent,
it doesn't sound like you think it's changed much since that evolution, even though the economics of the national economics have changed.
The best venture capitalists, if you have your choice, you often don't, but if you have your choice, pick a venture partner who's really going to be your partner, who has strong operating experience, been there, walked in your moccasins, has been a CEO, and has seen it come and has seen it go, and can really teach you and can really hold your hand. And whether it's big brother or father or whatever, but some mentor who can really, that's the most important part about venture capital. The capital part's just green, right? I mean, that's just money. But and that's not particularly important. I mean, you need it, but it's lube oil, to make it go. But the most important part of venture capital is the value added of smart guys who've been there with real experience, who've walked in your shoes, and it can help you out.
It sounds like a natural tie-in to what you're doing in Oregon at the Health and Sciences University. Talk a little, because it sounds like the same kind of mentoring approach to company development and to technology development.
Well, I had known about Oregon for over the years. I used to sit on the board of a company, Protocol Systems, up there. So I knew something about Oregon, but to be honest, by pure happenstance, just about the time that the Department of Biomedical Engineering here was being formed, a couple of years ago, and the new building was going up. I happened to be at a get-together and just overheard somebody say, this is really amazing. 2 departments of biomedical engineering being started on the West Coast at the same time. And I was pretty much aware of all biomedical engineering departments all over the country, so I was a little startled by that, and so I sort of tapped the guy on the shoulder. I said, well, I got the Stanford part. Where's the other one? He said, Oregon. So I looked on the web, a couple of days later, and discovered that essentially the engineering school up there, Oregon Graduate Institute, OGI, which is sort of the Caltech of the Northwest, and the medical school had sort of welded together. And it's pretty infrequent. I mean, I could only think of one other time when I had seen that occurred, and that had been in the UK, when the Imperial College, which in this case was the engineering and science school, had merged with a medical school. But it was in a mirror image, but it was the same idea. And that's been an extraordinarily successful marriage. And so I thought to myself, this could potentially be quite a successful marriage. We'll see.
I know that you're strong on the cultural differences between the community in Oregon and the community here in the Palo Alto Bay Area. Talk just a little bit about what you see as the difference. 2 projects similar, 2 programs similar in their intent and goals, but very different in their cultures.
Well, indeed, the culture of our entrepreneuring is probably the most important part about entrepreneuring. If the truth be told, entrepreneuring is really not about money. It's really not about technology. It does have a lot to do with markets, but it's mainly attitude. And I was always curious. My coming from a sort of a British family, I was always curious, for example, why the UK had never been able to pull this off. I mean, they bright guys and lots of capital and worldwide markets and good technology and spoke proper English. So why they never could sort of get it glued together. And so I would eventually start a couple of companies in the UK to try to understand what was different. And it led me to a lot of insights. When I went to Oregon, Portland, I had a very strong sense that this is very much like Europe. Silicon Valley is very libertarian. You know, government should be sort of out of sight, out of mind, keep the potholes covered, right, and filled up. But other than that, and the clean water running, but other than that, the lights on. But other than that, that's sometimes the hard part for government. But, you know, other than that, just sort of stay out of our way. And so very libertarian. Also, Silicon Valley is highly individualistic, sort of live and let live. Look, I'll do my thing, you do your thing, I'll stay out of your life, you stay out of my life. You don't step on my toes, I won't step on your toes, and we'll just sort of go about our business. So very individualistic. Just on those two dimensions alone, both in Europe and in Oregon, but I've noticed it true in North Carolina, where about 10 years ago I started a venture fund. I noticed it also then, and it's probably true in many places other than Silicon Valley, is over on the libertarian part in Oregon, government is not off stage. Indeed, it's the 800-pound gorilla in the center of the stage. I think that comes because it's a state which has largely been born and run on massive amounts of U.S. forestry stuff and the Columbia River project and marine fisheries. So government was always a big, important player, always was. They continue to think of it that way. Over on the individualistic side, not only do they believe, and again, this is very true in Europe, not only do they believe that they don't have to not get involved with your business, indeed they feel they have an obligation, indeed a duty, indeed a calling to make sure that somehow that what you do is sort of in the collectivist's best interest. So it tends to have a very strong collectivity. You see the same thing in Japan, where the nail that stands up gets beaten down. Individualism is not is not really accepted comfortably in Japan, and it's not in many ways accepted comfortably in Europe. And those who are quite individualistic, Richard Branson starting Virgin Airlines and a few others, they are quite noticeable and quite abnormal, quite different. And whereas here, I mean, University Avenue is populated with them. You know, I mean, they're all over. So it's just a different mindset. So I really think entrepreneuring is as much a matter of attitude and value systems and worldview as almost. It's not technology. It's not capital. It's not a more advantageous tax situation. It's being opportunity preferent as opposed to risk adverse.
You know, unfortunately, we're drawing to the end of our time here together. Let me ask you one final question. You're now in a mentoring role, helping others to develop technology and companies out of them. Given the opportunity to run the right organization, given the right technology, would you go back up to a startup role? Would you be a CEO of a startup again, or are those days past for you?
Well, being a CEO and doing a startup, you have to understand what I was trying to do. I was trying to make what I have called, by shorthand, profit-powered social engine. That is to say, an engine of social betterment that would do some real social good, that was run not by grants, not by charity, not by taxes, not by handouts. You just ask for the order. You run on a profit, where you end up with more left over than the money you put in. I started that with the core platform of a for-profit company. I didn't have to convince for-profit companies to make a profit. They were wired that way. What I had to convince them was that you could make a profit by doing social goodness. I think that was what came out of Melcor, came out of Natus, comes out of most of the other companies that I ended up building, which was, whether it be in the environmental area, the healthcare area, clinical medicine, education, These are all areas we could do some real social good and make a profit doing it, profit you can plow back into the business to grow the business. The interesting problem is can you mirror image, can you do that from the other side and start with a nonprofit platform, of which perhaps a subset would be academia. Here you don't have to convince them to do social goodness. They're wired that way. What you have to convince them is it's okay to make a profit, right? And the words of my department chairman keep ringing in my ears, right? That's Philistine. And yet, the single largest problem, I would say, in academia today, and indeed nonprofits in a more general, is they're struggling financially. I mean, the perfect economic storm has hit them too. And if your mission is important enough, you should make it as independent as you can from charity, from handouts, from taxes, from government support, always going to the government as a patron. You should get self-sufficient, autonomous, and simply ask for the order and end up with more money coming in than what it is you use to develop your technology, take your product out there. And that notion of a profit-powered social engine should work over on the nonprofit side and the academic side as well. So what am I doing sort of at this point in my life? I'm testing that model to see if I can make nonprofits, academic organizations, actually grit their teeth and make some money.
Well, Bill, I think if anybody can do it, you can do it. Thank you very much.
Thanks for taking my question. You said you went to business school because you're interested in managing scarce resources. Have you come to any conclusions about the future of medicine with the continued rising cost of medicine?
Yeah. There is actually an alternative model that we use in this country for a number of reasons. Two bottle of wine discussion, but there's for a number of reasons. We view education as a social entitlement, certainly through high school, arguably up through junior college, to be paid for out of the public purse. Yes, it has an individual benefit, but it's sort of is for the common social weal, right? I mean, for goodness, and it's just something we ought to invest in because it's the tide that raises all ships. So education is an entitlement in this country, and we pay for it. And arguably, healthcare should become the same. Now, in every other developed, virtually every other developed world, they see the synonymy of that, and that's how they do it. We're the one holdout. I think our model of healthcare was designed at a time when a relatively small fraction of the populace needed healthcare, so we could sort of, at the margin, take care of them. And medicine wasn't that expensive. Now, with an aging population, and that very small fraction is going to become a dominant fraction, and healthcare is very expensive, the model doesn't work.
Well,
so,
we fund health education on a local level. Are you advocating a single payer system, or would you like to see healthcare funded at the local level but become that same kind of entitlement?
Well, again, this is a two bottle of wine discussion, but one of the interesting things is if you fund health education, going to medical school on debt, then you perforce move the person who received that education into a position where they have to go essentially make excess income to pay it back, right? So it's a self-fulfilling problem. And I think you have to decide, is the education of a physician a social good or an individual good, right? And as long as we think it's an individual good, we'll make the individual pay for it. And the same sort of thing can be said for school teachers, for lawyers, for a number of other professionals. But healthcare, unfortunately, is the one which is about ready to break.
Hi, I'm Amy Angel, and I'm a fellow with the Biodesign Innovation Program, and also from Oregon. So I'm really interested to hear about the OGI-OHSU combination that you're working on right now. And given the culture in Oregon you spoke about, do you think you can institutionalize or develop an entrepreneurial culture there And if so, can you share some of your ideas about how you will do that through that program?
Well, I think part of the problem in Oregon is, and I say Oregon because it's a good example, but it's you see it in other parts of, I mean, you see it in Europe, for example, right now, is, I mean, the hard numbers is Oregon is 50 out of 50 in unemployment. It's 50 out of 50 in the worst bond rating. It's 50 out of 50 in the shortest school year getting shorter. It's 50 out of 50 in the highest incidence of homelessness per capita. Now, there are not many capitas, but so therefore it's a small base, but homelessness is there's a fair amount of it.
Does that come out of that collectivist culture, do you think?
Well, I don't know where it comes from, but, you know, by any metric, this is a train wreck, right? So, you know, just the outside observer, I say, look, these aren't my numbers. I mean, I'm sharing it. I mean, I'm just looking at them. There is this sense that somehow, yeah, that's true in some sense, but hey, you know, and a little Pinot, and that's why I moved to Oregon. And I think I think therein lies the problem. And until, well, you know, so we were talking earlier. In fact, you and I were talking about your wife getting an epidural. I will never forget the moment that a woman told me, "Oh no, I'm going to have natural childbirth." Right? Okay, I'm here if you need me. Right? About an hour and a half later, I get a stat page. I come running on up to the delivery room. Nurse says, "Lady in 3, man, she really needs an epidural, spinal." God, she just. And so I went running in, and she says, "Doctor, I need this epidural. Get that thing in there." And so I put it in. I said, "I thought you." And she says, "People told me it was going to hurt, but nobody told me it was going to be pain." I think that's the problem in Oregon. They know existentially that it's going to hurt, but there isn't yet pain. And when it gets to pain, then I think there'll be change. But right now, as the guy who told me in the seat next to me flying back when the first time I was up there, he listened to what what do you do, what do I do? I told him what I was doing. He looked at me and says, "You know, if I wanted to work that hard, I would have stayed in California." This rings true, doesn't it?
So I guess I'm not moving back.
Yeah. I've only been up there 3 months, and people say, "Yeah, you got it.
Thanks.
Yeah.
Hi, Tom Lee. I'm a graduate student in electrical engineering and also a student in the Biodesign program. I have 2 questions, actually. The first is, you talked about your medical training and how it helped you see the problems and also being able to connect problems with solutions as an engineer. Given the cost of medical education these days and the amount of time you need to invest, is it worth it for an engineer like me to go to medical school? Or is it better to just kind of develop a close relationship with doctors to get that connection? The second question I have is, you mentioned being a sort of profit-driven social engine. In Silicon Valley, we seem to have pioneered this idea of an academic entrepreneur. You have these professors who sort of take their sabbaticals and go start companies and come back and sort of shuttle back and forth. How do you see that as something that fits with your vision, or how does it fit in?
Yeah, the first question, is it worth it? And boy, that is a 2-bottle-of-wine discussion. That is it worth it financially? Is it worth it emotionally? Is it worth it socially? Is it worth it intellectually? At the end, if it's worth it to you in your sense of sort of Zen completeness of what it is you would like to do in life, it is worth it. Right? Because none of us gets out of this alive. So, if it's what you want to do, you probably ought to go do it. If it's something you're doing strictly because you believe it may enhance you financially, or it may enhance your resume, or enhance whatever, I'd open another bottle of wine and we ought to have that discussion, because that's probably not the reason I would do it.
Would you say it's in a business school?
No, I mean, you got to understand, engineering school is just as expensive as that. It's just that the costs are hidden. You don't see the costs. They're picked up by training grants, National Science Foundation, whatever. It's just as expensive in engineering school, but you're shielded from it. Graduate education is graduate education. It's expensive. So we're only talking about payment vehicles. We're not really talking about the cost, right? The amount that is taken on as individual cost is different in those three areas. And I would say the same thing about business school. You got to understand that business school is metaphorically much like the first 2 years of medical school. First 2 years of medical school, you sort of learn the dress code. You sort of learn, you can recognize at 50 yards by the cut of the coat if this is a resident, an intern, a medical student, the RT, you know, the respiratory therapist, a nurse, you know, the ambulance driver, or a wannabe. I mean, you know, you learn the dress code, you learn the lingo, you learn the vocabulary, you learn all the acronyms. So, you know, no longer do you talk about weak hearts, you talk about CHF and MIs, and, you know, you start to talk in vegetable soup. And it's sort of an acculturation, but you don't really start learning medicine until you get on the wards and you start actually getting close to pain. It's the same thing largely in engineering. You know, you learn all this stuff, but frankly, until you actually get designing stuff, you're really not an engineer. So, you know, my sense, and in business, it's the same thing. You go 2 years of business school, you learn the vocabulary, you know, you learn the dress code, right? Power tie, Brooks Brothers button down collar, you're sort of pinstripe, you know. You get all that part together, right? And you learn how to walk the walk. Just listen to business students, right? I mean, they talk their own vocabulary. Listen to engineers, they talk their own vocabulary. Listen to doctors, they talk their own vocabulary, right? You got to get to the point where you're multilingual, so you can fake it in any way, right? I mean, I can, you know, if I put on my pocket protector and, you know, my things, you know, my sort of, you know, day's growth of beard, and, you know, I mean, I can look like any geek there is, right? Get in there, right, with my, you know, free BSD and my Linux and my compilers, you know, and my stacks and pushing down. I can be as geeky as the next guy, right? Or you can, you know, sort of put on your white coat and starch, a nice little white name, you know, and your badge, stethoscope in your pocket, right? HP stethoscope, you know, nice, with the right sort of worn sort of black sort of way it is, you know. Only youngsters wear it over their neck, right? You know, and you can take on the persona of a physician. Or, as I say, you know, put me in my Goldman Sachs best, Wall Street, right? And greed. And so it's each one of them are an entirely different culture. What you got to learn to do is to be able to be equally comfortable in all of them and bring them together and make something that no one of them could do.
Do you want to
No, we can keep going, sure.
rephrase your
Second question.
Oh, yeah, just the idea of, in Silicon Valley, we've pioneered this idea of an academic entrepreneur, and you were talking about a profit-driven social.
Yeah, I actually think that that's the model of the future. That's the model of the future. Now, there's actually a model, we've done this before, about 50 years ago. You know, universities were, for the most part, prior to World War II, first half of the century, were philanthropic, right? Rockefellers, Stanfords, Dukes, Carnegies, John Harvards, you know, I mean, that's what started universities. Or land grants, which were the equivalent funding. About 1952, with the advent of the NIH, 1960, Medicare, you know, we learned from the Manhattan Project that interacting between the government and the university, that could be pretty useful. And so for the last half of the 20th century, government became the patron. And we really, to a large extent, switched off the philanthropic model onto the government as a patron model, okay? And so we switched over. And in a sense, we now are moving to the next generation, which is where in the same way that you know, the Condi Rices and the Don Kennedys and the whatever could go in and out of Stanford and become commissioner of the FDA, you know, go in and out of government, back to academia, back and forth. We're now going to start, and have started, as you point out, going back and forth with industry. And that, John Hennessy, good example, right? I mean, that will become the dominant operative model in your guys' career.
Thanks, David. First of all, Bill, it's just really wonderful to have you here, your candor, and just watching you having conversations in the shower with yourself it's just great. I'm sort of one of these academic entrepreneur who flitted back and forth. This is now my third time out. And one of the differences that I see just in what you're talking about and your approach to this compared to, say, 6 out of the other 7 that have been here is most of the people come in and say, we're going to identify one problem, we're going to build a device to do it, we're not going to worry yet about selling it, we're going to get it to work, we're going to get it big, we're going to sell the whole thing all at once, and that's the goal. And yours are slightly different. You've said there's no one serving babies. Isn't that important enough to do something about? And we're going to go into this area with a device that isn't a $5,000 stint, but it's a $10 or $15 disposable headset. And that creates, certainly in the current medical environment, a very different company. And you didn't say we're going to take in $100 million and drive this to size. You said we're going to sell some, and then we're going to fund the company. We're going to grow it just like a business used to be growing. And I'm wondering how you found the reception to that sort of a concept within the finance community. Were they open to that? And how you actually did it change the way you built the company? You know, people's expectations aren't in 18 months we're sold in public, but we're building this as an ongoing thing, because the things you described just feel very different than the
Oh yeah, no, and you've put your finger right on it, and exactly how I do build companies. It mirrors the change in the venture community. With the original guys in the venture community who had been operating guys that build companies, real products, right, with real customers, with real receivables, right, with real profits, real quarterly earnings, they got it, right? I mean, that's a business. The problem is, and I indicated it, is that venture capital turned over to a quick flip finance business, just an investment thing. Nobody's really interested in the business. I mean, nobody who buys and sells stocks are interested in the business, right? The stock is a proxy, it's a security, right? It's a negotiable instrument. It doesn't, the stock isn't a company. And once you make that shift, then you start treating companies, what they do, you trivialize them to be quick flips. And that reached its zenith, right, in the dot-bomb, where there was no there, right? And so when it finally, collapsed and poof, in fact, it now is coming back to the old world order. In fact, I took my last company, Natus, public during the dot-com thing. Everybody looked at this thing and they said, God, there's no way. You mean you only grow at 40% per year? I said, yeah, year after year after year after year. For the last 15 years, we've grown 40% per year. Wow, that's so boring. God, we can never get that sucker out. And I said, just wait. There will be a moment when the thing implodes, when suddenly, very briefly, there will be a window which suddenly, 40% return, and, maybe. And I said, if that window comes, we can get out. Well, it came, and we got out. And now, of course, it's continued on to slide, and now everybody who's risk adverse doesn't want to invest in anything, right? And a whole different world. But, the world will change around. But you're right. I mean, that's how I build companies. And you could argue it's the old-fashioned way, or you could argue it's the only way. But it builds companies. It doesn't build it doesn't build investments. It doesn't build quick pops. It doesn't, build flips. The financial community is getting wrenched around. They still don't get it, right? They still have analysts out there hyping the stock, even when the SEC has already fined them. So, they'll get it. They're not the quickest studies in the world, but they'll get it. And, we'll get back to another one. But meanwhile, I can't wait. I got to go. There's another problem, more patients who need a problem fixed, right? And just get on with it.
Hi, I'm Mike Murray. I'm a student with the Biodesign Innovation Program. You talked about how the investment in healthcare, in IT, was lower even than agriculture. Is this a manifestation of the same phenomenon of doctors wanting things the way they're familiar with, the way they've been trained, or is there something different? And what can be done so that healthcare can take advantage of the benefits that IT provide? I mean, is it just going to require the current generation of physicians to retire and a new generation of wired kids to become doctors?
Well, there's an analogy. All of what you say is true. United Airlines struggling, but United Airlines, because of past things, have ended up with the pilots owning a substantial fraction of the airline in their retirement fund, and they actually sit on the board of directors and whatever. And it's interesting when Airbus and all the other sort of newer people came in and wanted to sell airplanes that were fly-by-wire. And of course, these the pilots who are the senior pilots, right, and who are sitting on the board of directors are pilots, real pilots, real men sit in a leather seat. Dials go like that. That is look, and this is feel. You guys can have wires, those little foo-foo computer chip things, but you got to understand, I'm going to sit in a leather seat, and we're going to push this thing forward, and it's got to have the right F, and all the little dials are going to go like that. Doctors are the same way. It's what I learned, it's what I'm comfortable with, and I'm the MD in charge, and we're going to do it my way. And now, I have to say that the Airbuses and the whatevers have in fact emulated it, right? They have a user experience which feels like it had been built by Boeing, but in fact been built by a foo-foo Frenchman. But it's got the look and feel. And I would say that when we get healthcare so that the physicians can go have the same look and feel, right? And the IT is completely invisible. I rode the other day with a guy in his new Lexus, right? Doc, cardiologist, making too much money, in a new Lexus. And I commented, I said, there are 22 computers in this car. He looked at me, right? But they're all invisible, all invisible. And that's the way we have to get it. We have to get so embedded that information processing and information technology is invisible to the healthcare providers. And once it's invisible, and once their life just somehow magically gets easier and results get better, and it'll get adopted.
Great. Well, thank you very much.